Well, good afternoon, everyone, and welcome to Superior Health's Exploring Best Practices Related to the ABCSs of Heart Health, a structured collaborative. This is our very first session together, and we're really excited to have you join us for this series. And we're really excited to learn and to hear from you all as we work together through the structured collaborative as well. My name is Andrea Boucher. I'll be your presenter for today's session. Before we dive in, I just wanted to go over a couple of housekeeping items. All of our sessions are going to be recorded. I know we hope that you're able to attend us at every session, but if not, you do have the opportunity to go back and view the recordings each month. And we do want to make this session as interactive as possible. So if you do have access to a camera, we would encourage you to use those. And also feel free to jump in at any point during these sessions if you have any questions or comments. You can feel free to interrupt us and ask us any questions. So we'll do some introductions really quick just to get to know everyone who's participating in the collaborative. And how we'll do that is I will call your name, so you can unmute and tell us your name, your title, your organization, and location, since we do have organizations joining us from across various states today. And then state why you're interested or what interested you most about participating in this collaborative and maybe something you'd like to get out of these sessions that you're most excited to learn about. So just really quickly, I'll just go through our Superior Health team to introduce themselves. So I'll just go through my screen as I see everyone. And Carrie, I have you first.
Thank you, Andrea. Hi, I almost said hi, Carrie. Hi, everyone. My name is Carrie Finley, and I'm a project specialist with Superior Health Quality Alliance. My background is in nursing, and I'm based out of Madison, Wisconsin. My home organization is Metastar, and I believe I'll pass it off to Jerry then. I see her next on my screen.
Hi, I am Jerry Hineker, and I am with Stratus Health, which is the QIO in Minnesota. I'm a registered nurse by background, and I will pass it over to Rachel.
Hello there, my name is Rachel Dibble. I'm a Quality Improvement Advisor with Improve Health.
And let's go with Casey.
Thank you.
My name is Casey Zimpel. I am a quality advisor for the Wisconsin Hospital Association, and I am a registered nurse.
Thank you all. So that is our Superior Health team. So I will go through our participants. And April, I see your team has joined us. So thanks for gathering all of you together. And if you can just kind of go through and share who's joining us today.
What am I doing? Hi, well, I'm April, and we have several nurses that are out in primary care doing a lot of hands-on care with patients with hypertension. We have Danny, Marilou, Kayla, Mary, Grace, and Karen. We'll go around the room. There's several of us sitting in here during our lunch hour. So
great. Thank you so much for joining us over your lunch. Appreciate it. All right. And Sarah, I have you next.
All right, I'm Sarah. I am a registered nurse, clinical mentor, which is a director of nursing over the neighbors of Dunn County in Wisconsin on the western side. Interested because obviously we have a large geriatric population that we care for every day.
Wonderful. Thanks, Sarah. Thanks for joining us. And Gina, if you can share your name, title, organization, and why you're interested in participating. And Gina, if you're talking, you're on mute.
Hi, I was trying to get all set up in my computer. I came from downtown for a meeting, but I was ready to type in the chat. So this is Gina Aquino. I'm the RN Clinical Quality Facilitator at Henry Ford Macomb.
Thanks, Gina. And what are you interested in? Why are you interested in participating in this collaborative?
While back, me and Andrea, we collaborated together to set up a self-measured blood pressure with our MAs, so using the medical assistants to help doing virtual BP rechecks and using our EMR. So one of our issues was having loners. So being able to have patients that are out of control have a BP device at home to use. So Andrea knew right off the bat when she sent that over to me that I would be really interested in here is, you know, gathering best practices and sharing where everybody's at to help improve our BP and control rates.
Awesome. Thanks so much, Gina. Glad you're able to join us.
Thank you.
All right. Well, just wanted to give an overview since this is a structured collaborative so that you all have a clear understanding of kind of what to expect over the coming sessions. Each of our sessions is going to follow a structure that will really help us guide discussions. We'll have presentations, but we really also want to hear from you all too and really hopefully see some improved outcomes. Our meetings are scheduled once per month to really allow you time to digest the information that we share here and talk about and bring it back to your organization. The goal is that we have the same group of participants, whether that's you or someone else in your organization that is continuing to participate throughout the series so that you really have all of this information and that you're all learning from each other as well. But by participating with us in the structured collaborative, your organization will receive blood pressure devices so that you can either start or enhance your self-measured blood pressure program. And we will also be providing one-on-one technical assistance, just checking in with you towards the end of this program and really beyond that to assist you with that and any questions or resources or anything that you might need within your individual organization. But before we get started too, we did want to ask you to complete the pre-evaluation. If you have not had an opportunity to do that yet, we will add the link in the chat. This is really helpful for us to gauge the effectiveness of these programs and really determine if the information that we're sharing is helpful. So if you're able to fill that out, you can do that during this session. We would appreciate you being able to do that. But our session formats are going to follow kind of this structure. We'll do a welcome. We'll typically start ourselves off with a polling question. We'll have some round robin discussion. This will be at future sessions. So we'll let you know kind of what discussion topics we'll be reviewing at the next session and kind of revisiting those and having a round robin discussion at the beginning of those sessions. Like I said, we'll also have didactic presentations and an opportunity for open discussion and Q&A. So this is our upcoming collaborative schedule. We will meet on the first Tuesday of each month from February to June from 1 to 2 p.m. Eastern and noon to 1 p.m. Central Time. And our upcoming topics are going to be a part 2 of self-measured blood pressure next month in March. We'll be covering the A and the C of the ABCSs together in April, so aspirin use and cholesterol management. Talking about tobacco cessation in May and cardiac rehabilitation in June. So kind of moving into our topic for today, what our objectives are looking at are defining what SMBP is, identifying the benefits and the uses of that, and looking at what patients might be eligible for SMBP. So to start us off, just to kind of get a level setting of where your organization might be at, we want to do some polling questions. So just to see where you're at, have you ever implemented an SMBP program? Just want to see if this is something that you're familiar with this, or if this is brand new information from you. So the polling question should be pulled up on your screen. So if you can just take a moment and fill that out. But actually it looks like we've got a 50-50 split. Okay, looks like a couple of you have done SMBP and it's new for some of you. So that's very helpful for us. And then we do have another question of, do you have an SMBP champion in your organization? So this is someone who really is leading the charge of the SMBP work, is kind of responsible for responsible for implementing the program, for making sure that your teams are trained in SMBP, that those processes and workflows are in place. So we'll get that question pulled up for you and make sure that you have an opportunity to answer that question as well.
I have to apologize, Andrea. It is not launching for me. So it's a yes, no question.
Might have it.
Okay.
Did everyone see the second polling question? Or maybe it's not launching for me either. Oh, I have to click stop sharing. There we go. Okay. I think now it should be pulled up on your screen. So you have an SMBP champion, so you can go ahead and answer that question. Okay, so a few of you do have an SMBP champion and some of you don't. So we're kind of, like I said, a little bit of a mix here. So given that some of you are familiar with SMBP and some of you aren't, just to kind of do a quick overview of what it is, SMBP is referring to the regular measurement of blood pressure by a patient at their home setting or elsewhere, just typically outside of a clinical setting. So this slide gives a visual depiction of what SMBP ideally looks like, the patient measuring their blood pressure outside of that clinical setting, and that information is relayed back to the provider for that interpretation and clinical support. So SMBP is really helpful because it's enabling clinicians to better diagnose and to better manage patients with hypertension, and also really helps the patients to take an active role in their healthcare and in that process as well. Through this process, the patients receive training from their clinical team on how to properly self-measure. And this can really be done in about like 5 or 6 minutes by a nurse, a medical assistant, whoever you designate as that person to provide that to the patient, and helping the patient to prepare for measurement, learning how they should properly position themselves, and the instructions of how to do that in their home setting. Also, along with that, really one of the biggest pieces is patients sharing those readings back with their healthcare providers. There's a lot of different ways that patients can do that. We'll cover that in a couple of slides. But really that interpretation of those SMBP readings are essential. So this is what's used for that, whether it's diagnosis or management of hypertension, because patients without an existing diagnosis of hypertension can also benefit from this as well. So after those readings are interpreted, that feedback and clinical support are provided. So that could be regular one-on-one counselings between a clinician and patient, whether it's web-based, it can be telephonic support, tools and resources, or even educational classes that a patient can be referred to. So there are many benefits to patients completing SMBP, since the measurements are typically going to be taken in the patient's usual environment. That's where they're going to be most comfortable. It provides multiple blood pressures over a longer period of time, and this is going to be more representative of what a patient's true blood pressure really is. So it's giving a more timely and precise initial diagnosis of hypertension. Those out-of-office blood pressure measurements are recommended to confirm the diagnosis of hypertension. There's a significant number of patients who have different blood pressures outside of the office setting compared to when they're in the office. It also helps give a reliable estimate of the effectiveness of a patient's antihypertensive medication, and really gives that accurate titration of medication when needed. So if a patient does need an adjustment to their dosage or some type of change in their medication, it helps with that. It also helps to confirm elevated office readings if that's what the patient is showing in the office. And then also helps to differentiate between white coat hypertension and sustained hypertension. So white coat is when people have high office blood pressures, but don't have high blood pressures outside of the office. And then lastly, it's helpful to detect patients with masked hypertension. So this is kind of the opposite of white coat, when people have non-hypertensive blood pressures in the office, but then they have high blood pressures when measured outside. So some last additional benefits of SMBP helps give a better understanding of the patient's medication needs, whether they are using their medications properly, if that dosage is correct for the patient, really helps to determine if that medication, if it's taken as prescribed and taken correctly, is appropriate for the patient. Helps to assess control of blood pressure at different times across a 24-hour period. Again, since that patient is measuring outside those normal office hours, like a 9 to 5, it's helpful to get a more accurate picture of their blood pressure throughout the day. Helps to decrease resistance to treatment. So this is really about empowering patients, helping them to feel more involved in their care, that they have the ability to self-manage their condition. Because patients who engage in SMBP, they might be more likely to, take action to improve their health in other ways too, outside of just measuring their blood pressure. Also helps to improve access for those with barriers related to receiving care. If there's any, transportation issues to getting to an office, it's helpful that they have this available within their home. And there's also been studies that show improvements in systolic, diastolic, and mean blood pressure. There was a 527 patient trial that showed that home blood pressure monitoring, in addition to self-titration and telemonitoring, actually decreased systolic blood pressure by 12.9 millimeters of mercury. So that's a tremendous benefit, and obviously really helpful for those patients who have high blood pressure. So in order to start an SMBP program, it's really important to understand who can do what in the SMBP process. So these next couple of slides are going to outline the scope of practice for SMBP support. So there are certain things that have to be done by a licensed clinician, but there are opportunities for other care team members to get involved in the SMBP process and work with patients as well. So what must be done by a licensed clinician is diagnosing hypertension, prescribing the appropriate medications, providing SMBP measurement protocol. So this is the frequency and when a patient should be measuring at home, the interpretation of those patient readings, any medication titration needs, and then providing lifestyle modification recommendations. On the other side, there's also things that must be done by the patient. So obviously the patient needs to take their own blood pressure in their home setting, take their medications as prescribed, make those recommended lifestyle modifications if that was recommended to them by their provider, send their SMBP measurements back to the care team, and then communicating any side effects that they might be experiencing. So then this slide outlines what can be done by an SMBP supporter. So it doesn't have to necessarily be a licensed clinician. It can be a medical assistant, a nurse. There are community health workers who can engage in some of these pieces as well. So really providing that guidance on home blood pressure monitor selection. What we recommend is using devices that are on the validatebp.org device listing. So all of these devices have gone through validation testing to make sure that they are clinically valid. So those are the ones that we would recommend to be used for at-home monitoring. If needed, provide a loaner device, and we'll talk a little bit about what that might look like on the next coming slides. Provide training on how to use that home monitor. So what does the patient positioning look like? How does their actual physical monitor look like? What are the buttons you have to push on it? Going through all of that with the patient as well. Validate it against a robust machine. So really what this means is comparing it to the in-office readings that you are getting in the clinical setting. And then providing training on how to relay that SMBP data back to the practice. So this can vary from patient to patient, device to device, but really providing training on how the patient might do that. And then reinforcing what the clinician has directed them as far as how often to measure their blood pressure. Also, they can provide outreach support to patients using SMBP, whether that's phone call reminders, checking in through the patient portal, and sharing medication adherence strategies So maybe something that has worked for them can be helpful to share with the patient, and providing healthy lifestyle education. There's some additional supporter tasks, and this is really more so about that reinforcement. So taking what the clinician and the SMBP supporter has shared with the patient and reinforcing those pieces as well. And then the next couple of slides are going to go into some of the specific care team roles and what those care team members can be responsible for. So for example, with medical assistants, measuring and recording the patient's blood pressure in office and providing patients with information and instructions as authorized by the physician. And then any non-triage communication. So this would be anything that's outside of the interpretation of the results of the blood pressures that the patient's sending in. For community health workers, it's really about that empowerment, empowering patients, coaching them through social support, setting goals. If the patient has any barriers that they might be experiencing to measuring at home, really working through that with the patient. And this next one's really important, is serving as the liaison between the patient and really the entire care team. So that community health worker can be that kind of point person to be that liaison, and also with community resources as well. If there's any community workshops or classes that the patient can be referred to be that point person. And lastly, engaging patients in preventative care, chronic disease management, and self-management. So assisting the patient with all of those pieces. For registered nurses, similar to medical assistants, obviously measuring and recording blood pressure, with nurses to teach the patients and families about the care and prevention of illness, administering medications, if there's any treatments that the physician has prescribed, to really review that with the patient, and then coordinate and deliver a plan of care with all members of the care team. So this is where you kind of hear that a lot with SMBP, that there's a lot of members involved in this. So really that communication between all members is essential. Your billing team is important as well. If you are deciding to be reimbursed for SMBP services, there are CPT codes available, and we'll go over them, I believe, in our next session. But really knowing and understanding what those codes are so that your clinic can receive reimbursement for that is important as well. And then lastly, pharmacists. Obviously, this is another big important person on the care team as well. Administering any medications that are consistent with what the physician has prescribed for the patient. Providing any patient education. Again, it has to be authorized by state law, so it might vary from state to state what the pharmacist is able to do. Do a medication review with the patient. If there's any communication that needs to be done with any of the other care team members, to make sure that you're consulting with those care team members. And medication therapy management. So those are all the responsibilities that would fall under the pharmacist. So if you don't already have an SMBP program in place, there are steps that you're going to want to take to set up your program. Identifying at least one provider and one care team member to serve as champions. That's why we asked the question at the beginning of this session to see if you have those people in place. So it sounds like some of you do, some of you might not. But those individuals are going to be your point people, learning about SMBP, training the rest of your team, and really, being that one responsible for kind of getting the program off the ground and continuing on with the sustainability of that program. And it's important to make sure you're allocating the appropriate time, especially within a patient visit. So making sure you have enough time in that visit to train the patient on SMBP. This takes about 5 to 6 minutes per patient. Ensuring the device accuracy, especially if the patient has their own device. So this can be done in advance if you're using a loaner program, but obviously must be done during the visit if the patient's using their own device. And then averaging and documenting those SMBP readings, and then preparing the device for the next patient if you are implementing a loaner program. So that includes any like cleaning and disinfecting part of that process. So it's about 5 to 15 minutes total per patient within the visit. to complete an SMBP process. So again, before you start your program, there are certain questions you'll probably want to have answered. So you'll want to really design your processes with these questions in mind. So how will patients be identified as candidates of SMBP, and how are they going to be kind of flagged in your system? Who is going to be the team member that's responsible for training the patients on self-measurement? How are you going to get the readings back and the device, if you're choosing to do a loaner program, back from the patient? Is it a follow-up appointment where the patient comes in? Who would that appointment be with? Is it a patient calling their results in? It's really something that you would have to determine works best in your workflow. Who is responsible for averaging and documenting and then notifying a physician of the SMBP reading so that that clinical support and follow-up can happen, and how is that going to occur? And then these questions are important to answer if you're choosing to do a loaner program. So who is going to track the distribution and return of the devices? Who's responsible for disinfecting those devices, and where are they going to be stored? Because obviously, you know, I feel like space is always limited wherever you go. So where are you going to keep those devices? So as you're thinking about who you would want to identify for SMBP, who you'd want to work with, it can be patients with or without a diagnosis of hypertension. So patients with a confirmed hypertension diagnosis, those are really essential to work with. You know, those patients should be encouraged to have their own validated devices, since they're typically going to be monitoring over an extended period of time. If they cannot afford their own device, that would be where a loaner program could be helpful, if you do have that available. And then patients without a confirmed diagnosis, those patients might be considered at risk based on some of their in-office measurements. So they can also benefit from SMBP, again, to kind of rule out masked hypertension or white coat hypertension. But really, no matter which kind of route you go, the patient has to be willing and able to self-measure their blood pressure at home, because if they're not willing to do that and they're not engaged, they're not going to be measuring at home. They won't be sending you their readings back. So you want to make sure that that patient is engaged and interested in doing SMBP. So this slide outlines some methods for obtaining patient readings and getting those back. But you want to make sure you're identifying not only works for you and for your organization, but also for the patient. And this can vary from patient to patient. So like I said, it could be a telephone call. It could be them calling their results in, a secure fax. If there's an online way to do that, whether there's a spot in patient portal that they could submit this, or through some other website, maybe it's setting up follow-up visits, and that way a patient can bring in a written tracker card, whether they, you know, kind of wrote all of their readings down, and that could be scanned into their medical record. Depending on the patient's device that they're using, some devices have memory of readings that you could download. If that's available, you could do it that way. And then there's also Bluetooth devices. So if a patient's using a Bluetooth device and it connects to maybe an app, and you can download that information and incorporate it into their medical record, that's a possibility as well. But really what you want to do is make sure that these readings are averaged, and that is taken into a single systolic and a single diastolic blood pressure reading. There are resources available that assist with calculating this, or you could have the possibility, maybe there's a way to have that set up in the EHR where it's automatically calculated for you. But you want to make sure it's calculated into one average reading to give you a better look at that over time. Again, these are some tracking resources. So blood pressure tracker cards, some patients are very interested in just kind of writing their readings down. So those can be helpful, even if it's like a wallet size card to provide to patients. Again, the patient portal is a great tool that you could use to get the readings back, and then apps. It depends on the patient's device if it has connectivity to those apps, but there's also apps that the patient can download and directly add their readings into that as well. So this is going to outline what an SMBP workflow looks like, kind of starting with that identification of patients who benefit. So whether that's for the purpose of diagnosing hypertension, if it's to rule out that white coat or masked hypertension, for patients who do have hypertension to improve their adherence to their treatment plan, or their overall self-management of their condition. So you want to make sure your staff is trained on the correct use of SMBP, and making sure, similar to how you check in with them on blood pressure competencies once a year, would recommend to also do that with SMBP techniques so that they are training the patients correctly too. Training the patients would be the next step on how to correctly measure their blood pressure, going through the proper positioning, making sure that they have the proper cuff size, especially if they purchased it for themselves, because not all devices have extra large cuffs, but making sure that that patient has the correct cuff size for them, that it's a clinically validated device for the upper arm, and go over how to record their blood pressure measurements. And recommending that automated upper arm device for each patient. Receiving the SMBP data back from the patient would be the next step, and then averaging and interpreting those results. And then it's always important to follow up, but acting upon those SMBP results when it's indicated. If a patient is sending results back where there needs to be changes to their medication, you want to make sure that that's being followed up with the patient. Loaning any clinically validated devices to the patients who need them, making sure that those are tested for accuracy, making sure that they're calibrated and working correctly before every patient's use, and making sure that each patient's SMBP device fits properly. So this slide outlines what you can do with the SMBP results based on the patient's in-office reading and their SMBP results. So if a patient has normal blood pressure, so in office and out of office of less than 120/80, you would recommend that their blood pressure be rechecked in 1 year. If they're experiencing elevated blood pressure, both in the office and out of the office at 120 to 129 over less than 80, that would be a recommendation for a healthy lifestyle change, and also rechecking SMBP every 3 to 6 months. If a patient has an in-office reading of less than 130/80, but a home reading of greater than that, that would be where that masked hypertension is coming into play. So here you would initially want to be managing it as sustained hypertension due to that increased risk. You can also consider doing 24-hour ambulatory blood pressure monitoring for these patients as well. If the patient has in-office reading of greater than or equal to 130/80, but their home readings are less than that, of less than 130/80, that's where that white coat hypertension is present. So here, recommend rechecking every 6 months. If the in-office reading is greater than or equal to 130/80, but the SMBP is 129 or 120 to 129 over less than 80, that's white coat hypertension and also elevated blood pressure. So here is where that healthy lifestyle recommendations can be made on rechecking every 3 to 6 months. And then lastly, if they have greater than or equal to 130/80 in office and out of office, that is classified as sustained hypertension. So this is where you would follow the current hypertensive guidelines for treatment there. So feedback, again, is probably one of the most important pieces of SMBP. This is where you start to see patients experience better hypertension control with that additional clinical support. So I'll go over some examples, but they can be either web-based through the portal, if it's a phone call, an additional appointment, if it's counseling or counseling through a phone call, but making sure that adherence strategies are reviewed, whether that's using nurse case managers, electronic reminders, behavioral management teams. Those are all examples of adherence enhancing strategies that can be classified as clinical support. So I'll go over a couple of these a little bit more in depth. So what one-on-one counseling looks like could be a telephone call from a nurse or a pharmacist to help the patient in managing their medications and talk through any barriers they might have with that. Maybe it's a counseling session in person with a pharmacist. Community health workers can also help here, and they can help to relay that information from the patient back to the clinical team too. For patient education as clinical support, an example of this could be a nurse providing a telephone-based education. It could be based on those lifestyle changes to lower blood pressure. There may also be the opportunity for a patient to attend a community class. So, in a small group setting that's really focused on lifestyle changes. So that could be another piece of clinical support for patient education. And then lastly, those web-based or telephone-based support. This could be either online or telephone-based feedback system, whether it's through a secure patient website, through the patient portal, that patients provided training, access to web-based tools for medication refill requests, text and email reminders. Those are always helpful if a patient hasn't, kind of set up reminders for themselves, just to have text or email sent to them so that they can remember to measure their blood pressure or remember that they have an upcoming appointment. And then secure messaging with the clinician or staff. So if, a patient isn't, calling in and using that type of resource, they can always, do secure messaging through the portal and hopefully get their questions answered that way. So really what we want to do over the rest of today's session is think about next steps. So we've got a couple of questions for you. And since we do have a little bit of time, hoping we can have maybe some discussion around these and see if you do have an SMBP program, how you're doing this right now, how you're getting SMBP readings back from the patient, what care team member you have responsible as your clinician champion, and how you're providing feedback to the patient. And if you don't have that program, an SMBP program, that's okay. But maybe take some time to think about these questions, and we can also talk about it a little more at our next session too. But if anyone has anything they want to share about these questions, you can feel free to add it in the chat, or you can unmute and maybe talk a little bit about your processes. So how you get your readings back from the patient, and how do you provide that feedback? Hey, Gina, I saw you unmute.
I know, I was like, can I talk?
Go for it.
So I know, like, the one thing that we were struggling with was, how do we get the blood pressures into the EMR from the patient? And then, with the averaging piece, we do have the AOBP machines in the office where we do average the blood pressure in the office, and we document whether, in the vital section, whether it's an average BP. But it's sometimes we get patients sending in maybe 2 weeks of data, and then having this, trying to figure out with the staff who's going to average the blood pressure, and, the easiest way to do that. So I think that's, kind of been our struggle with, when we do get the patient doing their vitals at home or blood pressures at home, how, having that consistency. I'd like to have them send them in through the patient portal, because then we could just pull everything into our documentation, which is, there's no errors with transpose numbers and, so it might be elevated on the patient's sheet when they're sending it in through the portal, but the MA might transpose numbers and now it's not elevated anymore because instead of it saying 150, they put 105, so just making sure, a better process for that, I think would help. And then, we always try to get feedback from the patient on processes. And I know that, once we started implementing where they're adding their blood pressures into the portal, they found it easier. But at first it was like, why are you making me do this? It's just easier for me to jot it down on a piece of paper. And then they were seeing that they were getting more feedback quicker from the provider when they're sending the data that way. So it kind of, at first got that feedback from the patient by, them, just asking them a question in my chart. Are you having any problems with the process? And, what suggestions do you have? And so that's how we've been getting the feedback from the patient, instead of sending them a survey.
So that's great. So are their patients using different ways of getting their blood pressure readings back to you then?
Yeah.
Is it something you've
Yeah,
got?
so our patients that don't have access to my chart, they're using paper and they're either faxing it or dropping it off for the provider. And then, when it's that way, it's always, whenever you get paper, it's always piled up into the provider's desk. So then the provider can't really give feedback to the patient on quickly, when it comes through the my chart, usually providers can respond to the patient, let them know what they need to do, or, oh, this is great. Your blood pressure is in control. Keep doing what you're doing. I'll, follow up, in 3 months. So it's quicker to be able to give the feedback to the patient when it comes electronically.
Yeah, absolutely. Can definitely understand that. And I think maybe that I think this is a good example, Gina, of like the one-to-one assistance that we can provide. And maybe we can
Yep.
explore some different ways on how you can get whether the patient continues to use handwritten logs, how you can get that information quicker to the provider and quicker response back to the patient. I think that's something that we could explore for sure.
Yeah, that'd be great.
Can I just tell you what we kind of do? And I think we're a little spoiled and it does take extra time, but we have like a clinical assistant, kind of like a Huck type of person. They scan the little card into a message to either the RN pool or the provider, depending on what service we're providing it for further, instead of hand typing them all in, or we just scan the card into a message. And anyway, it goes a lot faster.
Yeah, and I know like here, they don't like us scanning stuff into like our Epic or, our EMR. They want the provider to review it and sign off, and, we sign, date stamp it. So that way stuff that's scanned in is appropriately scanned in. So that was kind of like because we thought about that too, like just scanning it in for the provider to review. But they want to make sure whatever we're scanning in is already reviewed by the provider and it's not missed. Once we scan it into it, because it sometimes go into like its own little corner by itself, and providers might miss an elevated blood pressure.
Hi, Gina. I was just going to ask a quick question. I'm sorry if you said this and I missed this, but I was just wondering for some of the patients who are using, the paper logs or handwriting it out, is there an opportunity for some of them do they just need education on using like a my chart system, or is it they just aren't these are the people who aren't going to do it?
Yeah, I think it's their preference. So thankfully, I shouldn't say thankfully, because of COVID, we have more people active using the patient portal because that's the only way they could get in for a visit at that time. Except for when they were really sick, we try to do the virtual as much as possible. Because of, staff being out, we had a lot of staff out with COVID. So we needed to be able to manage the patient. So we got a lot of people activated on, using the portal, but then there's still patients that aren't, they don't want to use it. We ask them every time a patient comes in, we ask if we could activate their MyChart, but then you'll still have people that are still reluctant. They say, nope, I'm not using it. Don't ask me again, So, it's just a small percentage, but usually it's our higher risk patients that are, with that small percentage.
Yeah, thanks for sharing, Gina. I think, there may always be some patients that have no interest in using the patient portal, I feel, but maybe there's some different ways to get that information
Get
back.
around that. Yeah. Oh, I appreciate
Yeah.
that.
Yeah. Does anyone else have anything they want to share in regards to these questions, or do you have any questions about this piece?
I just want to say, like, I think having the providers endorse giving out the cards, that gets a lot better turnaround. They are more apt to return it. I feel like they don't want to let the providers down, or having the providers support the process seems to be really helpful. They're pretty diligent in returning them in those cases.
Yeah, I think that's a great point, April. I think a lot of patients obviously look to the provider for a lot of things, and I think that's a great point. Like you said, don't want to let them down. So I like that. All right. There's some additional questions too. Whether you have or are considering a loaner program, if you have thought about these questions about, who's going to track how those devices are handed out and the return of those devices, how are you going to get them back? Who's responsible for disinfecting and where they're going to be stored. So I'm curious to see if any of you, I know Gina, you mentioned the loaner program, but if any of you have a loaner program, what your experience is with this, or what your thoughts are of a loaner program.
We have a loaner program. We don't have, it's not huge. I think we have just 10 that we loan out, and we have like clipboards that correspond to each one. And we have a sign out sheet we use to keep track of them on each clipboard that's hanging on the wall. And then we have like an expectation with the patient, and they kind of agree upon when to return it and to keep track of it, take care of it. And if they're late, we do a couple calls, reminders, see if they're coming in anytime soon to get it back. For the most part, it works really well. And then they bring their cards at the same time, and then we process that. We've had a few casualties of machines getting unusable when they're returned. That's kind of the risk with all this, as you probably all know, but.
To be expected, right? Yeah. Or not coming back. How long do you typically have patients kind of like check out their devices for?
21 days. We do about 21 days. Sometimes longer. Sometimes they return them sooner. Other departments have actually started getting more involved. Even our women's health department now is coming down, or they are looking into this process for some of their postpartum or pregnant women. I mean, so it's kind of, and they don't maybe need it as long. So, but 21 days is the average.
Yeah, that's great. And yeah, I think pregnant women are definitely a great population to do SMBP with. Like you said, they might not need it for an extended period of time, but if they are experiencing high blood pressure during their pregnancy, I think that's a great resource for them. So that's great.
Mm-hmm.
Any other comments, or do you have any questions for the Superior Health team? Anything we can answer for you right now? Or any other comments from the Superior Health team? Well, hearing none, I'll just quickly go over these next couple of slides. These are just some resources for you, really outlining specifically to the scope of practice. So if you're interested in learning a little bit more about those pieces, we have some resources on the different disciplines that can be involved in SMBP. And we would love to have you continue this conversation with us and connect. If you're not joined with us already, the link is available on this slide. But we do have our slides linked in the chat and a couple of other links as well as far as our evaluation. So if you can take a moment to fill those out, we would really appreciate it. But our next session will be in 1 month. Now I have to look at my dates, March 5th. At the same time, again, we'll be covering part 2 of SMBP. But if you do feel like you need any assistance in the meantime, you can feel free to reach out to any of the Superior Health team members, and we'd be happy to assist you in your SMBP program or anything else related to heart health, as that's what we're working on here. But with that, I think we can wrap up a few minutes early, give you some extra time back in your day, but really appreciate you all coming to join us today and hope to see you next month. Thanks, everybody.